Defects in the cardiac valves can either be of stenotic type or the regurgitant type. Stenosis is when the failure of the valve to open properly occurs, obstructing forward flow, whereas regurgitation or insufficiency is failure of the valve to close properly, allowing reverse flow or backwards flow. With either of these defects, the long-term consequences are potentially the same: congestive heart failure, increased risk for bacterial endocarditis. Endocarditis is inflammation of the cardiac valves leading to valve vegetations and dysfunction. Risk factors for endocarditis include valvular heart disease, congenital heart disease, IV drug use, indwelling venous catheters, and immunodeficient state. It can be infective or bacterial. Strep viridans is the most common and infects damage in prosthetic valves. Staph aureus is becoming a more and more common agent to cause endocarditis. It can infect normal valves, and it's most common in IV drug abuse. Staph epidermidis is associated with prosthetic valves. And then you can also have culture-negative endocarditis caused by the Haysick organisms. The rheumatic heart disease, which we'll discuss further, can also lead to endocarditis. Ligament-Sachs endocarditis is associated with lupus. It consists of sterile vegetations on the mitral valve that is caused by an autoimmune valvulitis. You can also get non-bacterial thrombotic endocarditis, or what is known as merantic endocarditis. You have sterile fibrin or platelet vegetations on the valves, usually the mitral valve mostly, and it can occur in the setting of cancer, typically colon or pancreatic cancer. The pathogenesis, you receive mechanical damage to the heart valve, followed by a fibrin or platelet deposition. You can colonize these areas with bacteria, and then you get formation and expansion of the vegetations. The mitral valve is the most commonly injured valve, the aortic valve next, followed by tricuspid valve. Right side endocarditis is more common in IV drug abuse. Acute endocarditis is usually caused by Staph aureus. It can involve normal valves. Large destructive vegetation form, and this type of endocarditis carries with it a high mortality, upwards of 50%. You can also develop subacute endocarditis, which can be caused by any of the other organisms, so slower onset, less severe symptoms, slowly damaging the valves. Complications of endocarditis include valvular insufficiency or stenosis, abscess formation, septic emboli causing infarction, and or abscesses in distant sites such as the brain or kidney or spleen. You can also get immune complex formation leading to glomerulonephritis and renal failure. Here is a morphological representation of endocarditis. You can appreciate the vegetations along the valve leaflets. Clinically, these patients will present with fevers, chills, weight loss. You can potentially hear a cardiac murmur. Blood cultures are chronically positive. You can have peripheral sequelae of endocarditis, such as raw spots, which are retinal lesions from septic emboli. Or you can have typical skin findings, such as splinter hemorrhages, ocellular nodes, and Janeway lesions, as pictured here, in the nails and the hands and the feet. Rheumatic fever is a systemic immune-mediated inflammatory disease that follows group A streptococcal infection. It occurs several weeks after resolution of the acute pharyngitis. It's common, most common in children 5 to 15 years old. Susceptible individuals make antibodies against streptococcal M protein, and these antibodies cross-react with native proteins, leading to an autoimmune reaction in various tissues. The most affected tissues are the heart, where it can cause pericarditis, myocarditis, or endocarditis, the joints leading to a polyarthritis, or the skin causing a classic rash known as erythema marginatum. On pathology, you get a membranous pericarditis, which can lead to symptoms of chest pain and findings on cardiac auscultation of a friction rub. Myocarditis is the most common cause of acute death in rheumatic fever, and is characterized by Aschoff bodies, which represent areas of fibrinoid degeneration surrounded by lymphocytes, plasma cells, and macrophages. Endocarditis associated with rheumatic fever typically involves the mitral valve and the aortic valve. Sterile vegetations form on these valves, leading to valvular insufficiency, and over time, repeated injury and infection leads to fibrosis and valvular stenosis. Long-term, these patients are at increased risk for CHF and bacterial endocarditis. Here's a gross picture kind of demonstrating the effects of rheumatic fever on the mitral valve, showing the thickening with distortion, commissural fusion, and ultimately stenosis. This is an entity that's seen still very commonly in the developing world, although less commonly in the United States. So clinical diagnosis of rheumatic fever is made using the Jones criteria. It requires two major criteria such as migratory polyarthritis, pancarditis, skin rash of erythema marginatum, subcutaneous nodules, and sydentate chorea, or one of those major plus two minor that include fever, arthralgias, increased acute phase reactants, plus evidence of streptococcal infection determined by serum ASO titer or culture. Functional valve defects can consist of either stenotic lesions or regurgitant lesions. Stenosis, you have hardened valves, systolic output obstruction. Due to that regurgitation, you have diastolic reflux through incompetent valves. Common causes include valve ring enlargement from cardiomyopathy, infective endocarditis, and chronic rheumatic heart disease. Aortic stenosis etiology typically is age-related sclerosis, calcification of the valves. More common in patients with congenital bicuspid valve. Typically, the aortic valve should be trileaflet, as you see above, but you can be born with a bicuspid aortic valve, and that puts you at greater risk. Reduction of valve compliance in orifice area decreases cardiac output and causes LVH. Clinically, this leads to symptoms of angina, syncope, and left heart failure. Long-standing hypertension can lead to aortic regurgitation or insufficiency. You can get dilatation of the valve ring as well in the setting of syphilitic aortic aneurysms, dissecting aortic aneurysms, and coarctation of the aorta. Chronic rheumatic heart disease and infective endocarditis can also lead to AI. Volume overload in the left ventricle is the end result of aortic regurgitation. Clinically, you can hear an early diastolic murmur that's heard best typically at the left sternal border. It's usually well tolerated until late in the disease with the onset of late heart failure, and therefore treatment of aortic insufficiency is largely guided by echo parameters. So you have to follow these patients with AI with periodic echocardiograms to determine the degree of LV dilation and the degree of depression of the ejection fraction, so that when it starts to approach 50% ejection fraction, or the LV dilates to greater than 70 millimeters, then at that time you would pursue valve replacement, regardless of whether the patient is symptomatic or not. Mitral stenosis is classically caused by chronic rheumatic heart disease. It can lead to left heart failure, specifically backward failure, where volume overload in the left atrium leads to pulmonary congestion and the symptoms that go along with that, or forward failure, which is a decreased filling of the left ventricle because of the mitral stenosis, leads to a decrease in cardiac output. Clinically, on auscultation, you'll hear an opening snap followed by a mid-diastolic murmur at the apex. You'll have symptomatic dyspnea and hemoptysis. Left atrial enlargement can be a result of mitral stenosis, leading to an increased risk for atrial fib, or dysphagia from compression of the esophagus because of the enlarged atria. You can also get hoarseness or irritation of the recurrent laryngeal nerve secondary to this enlargement. Mitral valve prolapse is the posterior bulging of the mitral valve into the left atrium during systole, which leads at times to mitral regurgitation. It is the most common valvular heart disease. It's usually idiopathic, but it may be inherited in an autosomal dominant fashion. Sometimes it's associated with Marfan syndrome or Ehlers-Danlos syndrome. Myxomatous degeneration of the valve leaflets can lead to this. It results from accumulation of dermestin sulfate or proteoglycan. Clinically, it usually afflicts young women. On auscultation, you'll hear a mid-systolic click with a late systolic murmur at the apex. Most patients are largely asymptomatic, but you can also appreciate episodic palpitations, transient chest pain, or fatigue. You have increased risk for mitral insufficiency over time, endocarditis and arrhythmias, etc. You treat symptoms with negative inotropes, so typically beta blockers or calcium channel blockers. Etiologies of mitral valve regurgitation include mitral valve prolapse, left heart failure, which leads to stretching of the valve ring from left atrial enlargement, chronic rheumatic heart disease, infective endocarditis. The syndrome of MR, the syndrome that MR leads to is volume overload in the left atrium and left ventricle, leading to on auscultation findings of a pan-systolic murmur heard at the apex. That's usually well compensated until late in the disease with the onset of left heart failure. Other valve diseases include tricuspid stenosis, which classically is due to rheumatic heart disease. You can also get tricuspid regurgitation, which is relatively common in the setting of right heart failure, endocarditis in IV drug abusers, and rheumatic heart disease. Pulmonic stenosis, which can be congenital, pulmonic regurgitation in the setting of pulmonary hypertension and right heart failure. Question. A 35-year-old female develops congestive heart failure, PVCs, and repeated episodes of tachycardia. Blood pressure is normal and no murmurs are discovered on exam. A chest X-ray shows a markedly enlarged heart. Coronary angiography is read as normal. What is the most likely diagnosis? So this would be a relatively consistent clinical vignette associated with patients that are afflicted with primary cardiomyopathies.